Hello guys, and welcome to this video to discuss about a case that is very interesting because we have different types of radiolucent lesions, okay? That's very nice for you guys to learn how to diagnose those lesions properly. So without further ado, let's see this case. We have a CBCT scan, and then we are going to discuss even clinical aspects, okay? Although we have only the CBCT scan here. All right, so let's see what we are seeing in this, which is the right side of the patient, and then of course you guys are realizing that we have some alterations here, right? So we have here some alterations. Let's discuss a little bit about these alterations here, right? So we have here first on the maxillary sinus, take a look at this. We have a hyperdense or radiopaque, because it's now of course CBCT, so we say hyperdense or hyperintense alteration attached to the posterior wall of the maxillary sinus, okay? So if this was completely in continuation with the sinus floor, then obviously you guys would describe as sinus membrane thickening. But now it's in the posterior wall, it's very well limited, homogeneous, and with the shape of a pedunculated lesion, and that's exactly the shape of a sinus polyp. Okay, so that's the first alteration that we are seeing here. That's a sinus polyp. The diagnosis is purely, or it's more than enough to be radiographic, okay? And that's your diagnosis, okay? Well, very good. Let's analyze a little bit this upper arch as well. We have a cervical lesion and distal marginal bone loss here, of course. There is the hyperdense alteration, so metallic restoration here. And then we have this situation here, okay? But you guys know that this is CBCT and we might have metallic artifacts affecting the diagnosis of this area, right, of the tooth 1-6. Now, if you guys want to read a little bit more about the articles about these artifacts, of course, the name, the keyword is beam hardening artifacts. Okay, so the metallic artifacts from a CBCT are usually called beam hardening artifacts. Okay. Now we have, of course, the edentulous region, but okay. So of course you might have a little bit of horizontal bone loss, so the level of the alveolar crest is slightly altered, but here in this case that's still fine. With experience we know that this is still enough to place a dental implant. So what would you do? You would move your axis to the edentulous site completely, and then you would do your linear measurements and your implant planning, most likely using implant planning software. That's the ideal situation, okay? But we have a video only about CBCT implant planning with implant planning software programs, and I will also put the link here on the top right corner of this screen, so it will show up at some point, okay? Now, of course, we have this metallic restoration here of this premolar as well, but then, to assess the adaptation here with artifacts is also a little bit challenging, right? I'm also realizing that this could be the third molar here, and this would be the second molar, but okay, so we are just discussing about the diagnosis of what we are seeing. All right, let's discuss about the lower arch now, and then we have, take a look at this. It's even in the screen to you guys, right? We have a hypodense or radiolucent lesion, but this lesion is now in continuation with the mandibular canal, okay? That's something very important, because if you do the extraction and the enucleation of this lesion, then you might consider the risk of paresthesia, okay? So you might have paresthesia, and you guys need to consider this as a possible risk. The patient should be informed before the extraction, before any surgical procedure. But of course, that's still a lesion, and you guys need to remove the lesion, right? Now, I assume that you guys realize that, take a look at this. This is a round-shaped lesion, okay? But, so the lesion is partially round, symmetric, well limited, right? very well limited, and then the first option here would be radicular cyst, of course, right? So radicular cyst, but associated to a endoperio lesion. Okay, so we have also the distal bone loss here. Okay, so we have the distal bone loss, the mesial bone loss we cannot see properly because the axis, take a look at this, the axis is here, right? That's the axis of this picture here that we are seeing, and then maybe it's not the best image to see the mesial bone loss. But we already know that this is an endoperio lesion. I can see the bone loss very clearly even here, okay, on the axial plane. All right, and then of course the parasagittal plane would be the one, the most important one to see distances here, right? So you have the mandibular canal. Okay, let me change the color now because I want to show the mandibular canal. Okay, so the mandibular canal I show in red here. Okay, and the lesion is of course here, right? So that's the lesion. Okay, very good. Now let's see. This is the most. Those are of course the most important alterations of the right side of the patient, and of course we have the horizontal bone loss, right? All right. Let's move this image now, and then we have now this situation here on the other side, right? On the left side of the patient. Okay. And take a look at this. The planes are tilted, so we need to centralize our planes on the lesions that we are seeing, of course. But we can see this periapical lesion, okay? And what's the diagnosis? Feel free to pause the video and, try your best. For those who are able to do it, congrats, because, of course, the main hypothesis here, the first hypothesis, is a periapical granuloma, right? So periapical granuloma, it's well limited, okay, but not like a cyst, not with corticated borders, not round, smaller, and everything. So that's the first hypothesis is periapical granuloma. And of course you want to move your axis to see the distance between this periapical granuloma and the mental foramen, or even now the mental foramen is here, right? So that means that the mental foramen is in this plane here. And then that means that our lesion is anterior to the mental foramen, but it could be still close to the incisive canal, right? So the continuation of the inferior alveolar nerve. Very good. So we need to consider this as well. And now we have the hypodense lesion. Take a look at this on the upper arch, okay? Now, which is the tooth associated to this lesion? We cannot tell by this image, okay? We cannot tell by this image. So then what we need to do? We need to see another, to move the axis and centralize all the axis on the lesion, right? And that's actually what's happening here now. So take a look at this. We have the lesion in continuation with this socket over here, right? So we have the socket, and then we have this lesion. And the lesion is very well limited. The lesion is large, the lesion is round, okay? The borders are mostly, corticated. There is a lack of continuation here of these walls here, so we need to centralize the axis again to see why this is happening. Maybe the expansion of the lesion or trauma or something. And we see that even buccal palatal extension is large as well, right? We can also see that on the axial plane here. Okay, so first hypothesis of radiographic diagnosis will be, of course, radicular cyst, but there is no tooth, right? So what happens here? The tooth was extracted, but the cyst was not enucleated, the cyst was not removed, and now the cyst doesn't go away, okay? So if the epithelium stays with all the structure, so not disrupted, then the tendency is that this cyst will increase in size due to the intracyst pressure, okay? And then, of course, this is now a residual cyst. Okay, so that's a residual cyst. The cyst is still there, and now we need to do another surgical procedure to enucleate the cyst, or at least to curate the cyst through the sockets that we still have. all right? That's the thing. So take a look at this. In this case, we have radicular cyst associated to endoperioral lesion. We have a sinus polyp, and then we have a residual cyst. So 4 very common lesions that you guys might find in your careers, okay? So that's why I decided to bring this to you guys. Again, treatment for the endoperioral lesion, extraction, that tooth needs to be extraction, and then everything curated, the cyst enucleated if possible, then irrigation with saline solution, very careful because there is a risk of paresthesia. But then, you know, that's basically the treatment, okay? And then rehabilitate the patient. But we are not discussing all the rehabilitation. We need to check the occlusion. We don't know the vertical dimension. We don't know how is the occlusion of the patient because we are analyzing a CBCT, okay? But this is the part of decision making involving the CBCT, all right? I hope you guys liked. Please give us your like. Don't forget to subscribe to be updating your